Thank you for joining the NELA Patient Pathways webinar over this lunchtime period. The purpose of this webinar is to try and give you some elements of good practice from some of our top performing NELA sites. So we've got 4 speakers for you over the course of the hour. I'm going to try and keep the presentations relatively short and quite punchy. I'd really like you to put lots of questions into the chat box so that we can have a really good Q&A session for the last sort of 20 minutes or so. If there are burning questions, I'll try and slot them in between the presentations, but otherwise we'll probably just try and package them all together towards the end. So this is the order that we're going to go in, and I'll introduce each of the speakers as they go. In terms of housekeeping, there's just a couple of things that we need to let you know about. So if I was talked about Q&A tab, if you have any problems, technical issues, just exit the webinar and restart Zoom. The recording will be available in due course on an online platform. And please do complete the post-webinar survey. That gives us really good insight into how useful you found the session. And we're really keen to know any future webinar topics that you might want us to take on. We're looking at webinars for the course of the year. So do complete that post-webinar survey, and we'll try and get some more interesting discussions going. So without further ado, we'll go straight into the first presentation. So Konstantinos Similis is a consultant colorectal surgeon at Addenbrooke's in Cambridge, and he is the surgical lead for NELA there. And he's going to talk to you about the MDT input at consultant level for emergency laparotomy patients in Addenbrooke's. Thanks very much.
Thank you very much. Thank you. So yeah, my name is Kostas, and I will describe our NELA experience at Addenbrooke's Hospital. Before this presentation, I was asked to describe a key element of the pathway which I thought made its difference in the outcome of our patients at Addenbrooke's. And I decided to talk about the specialized multidisciplinary input at a consultant level. Just to give you a bit of background and context, Addenbrooke's is a large acute hospital with about 1,400 beds, and all subspecialty services are available on site. The general surgery on call is made out of 16 surgeons, 10 colorectal and 6 upper GI, which makes it 1 in 16 on call, and that's a 24-hour on call. But on top of that, we also have 6 emergency general surgeons, and they come from the pool of the colorectal and upper GI surgeons. So they are made out of 3 colorectal and 3 upper GI consultant surgeons. And they work in 1 in 6 EGS rota, Monday to Friday, from 7:30 in the morning until 5:30 in the afternoon. So during that time, from 7:30 until 5:30, you have 2 consultants on call. And there are benefits to that. The benefits are that we have faster consultant input of the emergency admissions. There is faster consultant advice to the accident emergency department and to the GPs. We are able to run 2 emergency theaters simultaneously, and that also provides faster access of the patients to the emergency theater. Most of the days we have 1 consultant coming, being a colorectal consultant, and the other consultant being an upper GI consultant. And that way we can decide which surgery each person will do. So for example, if there is an emergency laparotomy for a colorectal pathology, such as colorectal cancer or inflammatory bowel disease, it will be done by the colorectal subspecialty surgeon. If it's an upper GI subspecialty surgery, such as a perforated esophagus, it will be done by the upper GI subspecialty surgeon. Also, on site at the hospital, we have other surgical consultants which are always available to us for advice, but also to physically come to theater and provide their input, their expertise and assistance. We have HPP surgeons, transplant, vascular, pediatrics, urology, and gynecology. There is multiple medical specialty consultants on call, available always for advice. The emergency department has 24-hour on-site ED consultant presence who are able to recognize critically unwell patients early and provide early input at consultant level and initiate appropriate early treatment. Perioperatively, there is early anesthetic consultant input and ITU consultant input. Postoperatively, interventional radiology is available 24 hours on site. Automatically, there is a geriatrics consultant input for frail patients or over 65 years old who come and see the patients on the surgical wards. Selectively, patient care is provided by the appropriate surgical subspecialty based on the clinical condition. For example, if it's a colorectal cancer emergency surgery, it will go under the colorectal team, which and the patient will have colorectal MDT input, including oncologist consultants, stoma nurses, cancer nurses. In conclusion, I decided to speak about the specialized multidisciplinary input at consultant level, which I think provides optimal holistic care to patients and overall improves patient outcomes. Thank you very much.
Wow, that's great, Kostas. Thank you. That's something certainly to aspire to. Sounds like you've got all bells and whistles in Cambridge. That's fab. There's no questions that have come through on the Q&A bit of the chat at the moment, so do put some in for Kostas. Just one thing that I wanted to ask you, Kostas, so that it looks really well set up. Have you had to develop any of that yourself over the last kind of year or two, or is that just the level of consultant MDT input that Cambridge always had?
One of the things that came on the NELA audit was that the geriatrics input at Addenbrooke's was not meeting the standards. So one thing we developed was one of the things I mentioned in the slides, that we automatically, through the electronic EPIC system, automatically the geriatricians will receive a referral to come and see the patients on the surgical ward if they are frail enough or if they're over 65 years old. And that is something that has been that has started over the last 3 months.
Okay, great. That's brilliant. And the other thing I just wanted to ask about was the sort of dividing up of patients into appropriate specialties, upper GI, lower GI. How does that work practically? Do you do that on a daily basis? Do you do it throughout the day? Does it happen at the end of a week? How do you divide them up?
It happens on a daily basis. And again, that's the benefit of having these two consultants available. And we tend to have one consultant being colorectal and the other one being upper GI. So daily, even from the moment the patient comes to the hospital, they will be allocated depending on if it's colorectal problem, go to the colorectal consultant. If it's an upper GI problem, go to the upper GI consultant. If that decision hasn't been made during the day, on the morning handover, that decision will be made. So within 24 hours, the patient will go within the appropriate subspecialty team.
Okay, great, fabulous. Right, there is a couple of questions coming through on the chat, so we'll come back to you later. So I'm going to hand over now to Mike Lewis. So Mike is a consultant surgeon at the Norfolk and Norwich University Hospital, and Mike's going to talk us through the benefits of their electronic booking systems for emergency laparotomy patients there.
Yeah, thank you. Yes, the electronic patient booking system is a fairly simple instrument, which I'll talk about in a minute. Just to give you an idea of our current configuration, we have orthopedics separate in two different trauma theatres. We have an additional minor plastics trauma list that runs 10 hours a day. So we have two emergency theatres effectively which run for 24 hours. And that covers everything else. That's gynecology, vascular, thoracics, pediatric surgery, urology, and of course, general surgery. We do around about 300, and I think the maximum has been about 400 NELA cases per year. We did have a AHSN peer review just prior to the pandemic 2 years ago, which was very useful to involve our management and all the involved specialties in agreeing processes to improve our sort of NELA outcomes. Some of these were taken up, and some, of course, have gone by the wayside because of the pandemic. But so we have a surgical care practitioner now in general surgery who's involved in the post-operative care, pre-operative assessment and workup for patients for emergency laparotomies, and she also runs an outpatient clinic afterwards. We wanted to cohort the post-operative patients, not the laparotomy patients, but that's proven impossible in the current climate. The agreed standard of care for post-operative patients is ongoing. We do an agreed pre-operative discussion of anyone who's high risk, which is highlighted by the booking system between the anaesthetist surgeon and critical care. One of our emergency surgeons has done a diploma in geriatric medicine, which we're hoping to bring forward to the other emergency surgeons, in partly to improve the patient care in terms of recovery, but and perhaps to ameliorate our poor showing in the geriatric input post-op on the NELA results. We also wanted a general surgical only emergency list, but that's a long way off. So we've had a booking system, an online booking system, which was developed 16 years ago in-house by one of our anesthetic colleagues, and it's regularly updated. It works really well. It's used for every patient that goes on the emergency list from every specialty, and what it does is, by inputting the hospital number or the name, it enables the automatic population of patient data, like most recent blood results, into the booking system. And so you can get an automatic generation of their risk scoring. So that originally was PPOSM, and the most recent software update, we now have NELA or SORT, depending on the patient. The having the risk scoring, it has proven to be very useful for managing the emergency theatres. This is the input screen that the surgeons use to put somebody on the emergency list. You put it in the hospital number, and as I say, it populates all the blood results automatically. If they are a NELA potential, there is another radio button that you can click, which gives you a number of additional questions to enable population of the NELA information. This is what it looks like online. So we have a list of patients awaiting emergency surgery. This was from last Monday. I've hidden the names. If they are green, they are assessed by the anaesthetist and ready to go. The red have just been added and have not been assessed, and the amber are awaiting assessment, have been acknowledged and are awaiting assessment. So on the left-hand side, the emergency theatres can move people up or down the emergency list, place them in a particular emergency theatre. We also have the COVID status of the patient, so that theatres are aware. And towards the right-hand side, you can see the type of operation, and also, of course, their risk. This slide just shows you the right-hand side of that screen, which shows the type of operation they're due to have and their risk score. So if their risk is over 5%, either through NELA or SORT, it will be automatically, there'll be an automatic alert. So what, as I say, this has been going on for 16 years. It easily identifies the high-risk patients as soon as they're put on the emergency list, and it enables, hopefully, optimal usage of the emergency theatre and staff. If the risk is over 5%, it alerts so that the anaesthetist needs to discuss with critical care consultant. On top of that, in terms of NELA, there's a facility for displaying all the NELA cases as they come up, so that we can easily retrieve the data for inputting onto the NELA database. And it also automatically emails NELA cases to the surgical care practitioner, so that they are aware of the case and can help with the inputting. So a simple instrument which works very well. I mean, it can be, I'm sure other units have similar booking systems, but this, by automatically generating a PPOSM or NELA, will obviously gives us 100% on our NELA output in terms of risk assessment. But it also alerts everyone in the emergency theatres, the staff, anaesthetists, critical care of the high risk cases. Thank you.
Thanks, Mike. That's great. So a few questions are coming through on the Q&A. So Claire Cheeks just put on, who developed this amazing system? It looks fantastic. So who was it that developed your system?
It's one of our anaesthetists, David Nunn, who he does the updates. I don't know what number he's up to now, but it seems to be updated fairly regularly. We've just, the recent one, as I say, is now changed it from POSM to NELA, and has given it the red, amber, green effect as well. So David Nunn is basic.
So somebody in-house created that for you. Brilliant.
Yeah.
The other, I'm not sure whether you mentioned it, but the risk scoring that automatically, you know, you're pulling information into a system. So you've got systems that are talking to each other, which is a major achievement in any NHS computerized systems, I think. So you get a pre-op risk score. What about your post-op risk score? Do you do it similar for a post-op risk score or not?
That really depends on the surgery performed, doesn't it? Rather than the any blood parameters or preoperative parameters. So it doesn't generate it online for us, no, but it's quite easy once you've got the preoperative to generate the postoperative.
Brilliant. And then Human Akvi has said, I would love to know about geriatric training for surgeons. Can you tell us a little bit about that, just for
yeah, so there's a diploma of geriatric medicine, which is a 6-month training offered by the Royal College of Physicians. It's mainly for GPs, psychiatrists, but also all allied health professionals are able to undertake it. I don't know its cost. We've had, as I say, we've had one of our emergency surgeons has taken it, and I think there's very positive input into his career.
Okay, so you've got additional expertise amongst your consultant cohort. It's great, brilliant. Right, and so Human Akvi has now said that she's going to recommend that diploma of geriatric medicine to all of her colleagues, so that's good. So that'll be on their CPD targets. Right, brilliant. So moving on swiftly. Next, we've got Leslie Jordan. Leslie is a consultant anaesthetist at Royal United Hospital, Bath. And she's going to talk to us about what's very coolly named Code Laparotomy, which sounds really interesting. So over to you, Leslie.
Thanks, Lindsay. Do you have my, hopefully you have the slides up there? Yeah, lovely. So I'm going to actually very briefly share our story in Bath, because it's quite interesting, and share that learning, and then share a few of the simple tools that we've implemented. So we've had a long-standing interest in emergency laparotomy in Bath, and we're one of the 4 sites involved in the ELPQUIC study, which implemented a laparotomy bundle that you'll all be aware of, and showed reduction in mortality in all 4 sites. Our mortality decreased from 13 to 5%, and we were really proud of ourselves and thought we got this. We introduced our Bath boarding card, which prioritised doing risk assessment and consultant involvement, and we implemented a lot of changes and thought, we've got this. But my message would be, don't declare victory too early, because it's the whole thing about how quickly changes cannot be sustained if you don't focus on them. So the end of the project, it was a research project. We had no ongoing data review, but NELA had commenced, so some data was being collected by a research nurse, but not in line with the teams or being fed back to the teams. So there was no review of data, case ascertainment was low, it was retrospective note review, all the junior staff had changed, and we generally felt that the bundle wasn't being delivered anymore, and we were quite right. So when we reviewed all of the data, our bundle compliance was poor and mortality rate had increased to 10%. So we did feel like we'd kind of been thrown to the floor, a bit like Rocky in these photos. So we relaunched our bundle, but really focused on the Q quality improvement work and sustainability element. And of course, we had a really good story to tell because we had the data about how the bundle had improved mortality when we had higher compliance with it, but equally when we weren't doing it, our mortality had increased again. So we really engaged all stakeholders, and it really did feel like this photo of running around everywhere, telling everyone kind of our story and sharing our data. So surgeons, anaesthetists, trainees, theatre teams, and also our executives. And we had a quarterly report to the board as well, quality improvement teams, and a hugely multidisciplinary engagement. And very importantly, what we did was really establish robust data collection, which has helped us to deliver all the changes that we've made and really involve the team in that. So the data is collected at the time of surgery with an iPad by the teams involved in that case, and then followed up by the quality improvement team afterwards. So they also chase whether cases have been entered, but also do the follow-up data. And again, very importantly, that compliance with our bundle and any interventions is fed back regularly, and the outcomes in a newsletter infographic as shown here, as well as with some run charts. So I'm just going to share some of those things that we've implemented that can be very easily implemented anywhere. And so this brings us to the code laparotomy, and it's really a bit of a theme for all of the work. But one of the people that we really did engage with were the radiologists, identifying that earlier time to diagnosis is obviously important. And often there's a lot of conversations about how urgent a scan might be. So they agreed that if there was a chance the patient needed a laparotomy, the only thing that had to happen is on the booking, the words code laparotomy would be used. So really, really simple. That would prioritise the scan, and they would guarantee a report back within an hour. So that's really helped with the speed of diagnosis, and with the boarding card as well, which promotes risk assessment and time required for that patient to be in theatre. It provides, both provide a really good common language, so there's not individual conversations going on, it's an agreed process. And that does work really well when the surgeons are using it. One of the things that we've identified is it doesn't work quite so well if the patient's on a medical ward or in the emergency department. And so that's our big focus currently to improve that. So having identified that the patient needs a laparotomy, of course, the next process was to get them into theatre promptly as well. So we already had in place a slightly modified NCPOD classification for priority to theatre, which is shown here, with A1 and A2 being life-threatening, either with or without resuscitation and needing to come to theatre within 2 hours. And then our category B would be the very urgent that needs theatre within 6 hours, and then C and D, urgent surgery, but not quite such, needing such speed to come to theatre. And so we had already, as I say, agreed the typical cases that would fall into those categories with all of the surgeons. So the ones that we were concerned with in terms of emergency laparotomy would be what we call category B patients. So having this already in place was quite useful. But what we really identified was that we wanted to prioritise emergency laparotomy patients, but we also didn't want to disadvantage other patients that might need to come to theatre. So we needed to work on the whole pathway. So we do have one NC pod list 24 hours a day, but obviously there's a variation in the amount of demand for that list, and so there are potential delays to theatre. So our solution was to implement this traffic light system, which essentially measures the quantity of emergency work that's booked and classifies then the status of our emergency theatre into green, amber or red. So this is it here shown. It's busy. I appreciate you won't be able to read all of that, but it specifies actions to be taken. So green, less than 6 hours, would be low risk of not getting to theatre in time, but equally being proactive about any of the CD, so less urgent cases that may be able to be put onto other lists that are free. Amber is a risk, that's 6 to 12 hours. So therefore we need to actively do some of those cases in other lists and start to discuss with managerial teams about potentially delaying or cancelling elective cases. And then red is the danger. So that means that then we would be cancelling elective cases to prioritise emergency ones. And so this empowers the theatre teams to actually prioritise that work. We obviously did a lot of work with managerial buy-in, and it's coordinated by the theatre coordinator and the anaesthetist coordinator. And so having something that's very formalised has really helped. We tested it using the model for improvement and developed processes around it, including the coordinating anaesthetist, which has really supported that. And so by February 2018, 91% of our emergency cases that did need to come to theatre in 6 hours, so our category Bs had achieved that. And our median time to theatre for emergency laparotomy for our category Bs is 3 hours. And in fact, we had I remember taking over on call one time at 5 o'clock, and there were 3 emergency laparotomies already running in 3 different theatres, only one of which was obviously our emergency theatre. And that was because of the implementation of this traffic light system. And it was really great to see actually that none of those patients were delayed, whereas they would otherwise have been if we hadn't had our traffic light system. But none of the, so that was also 3 theatre teams, so nursing staff, surgeons, trainees, anaesthetists, all staying late, but very happily staying late because they identified it was the right thing to do. And it was a completely different atmosphere to an overrunning list sort of thing. So that was also acknowledged by our chief executive, and they all got a letter of thanks. So there's been a lot of engagement with across the board really, and support of this work. We've also used it in capacity planning for our emergency theatre requirements. So we do have some category CD lists where we can again offload some of the emergency work. I love the electronic booking that's just been presented because we've been trying to get that for a while and we still haven't quite achieved it. Everything's delayed about 2 years, isn't it? As I'm sure we're all in the same boat. But what we also want ours to do is automatically activate the traffic light system because it's still a little bit individual. Someone has to work out those timings. So that's certainly an area for improvement for us. And these are just some of the run charts that we've had that we share back. So we didn't really have any impact on our time to theatre until we did introduce that traffic light system, very variable before, much more or much less variation afterwards. And that is still achieved up to date. So just very lastly, and finally, I just wanted to share one other very simple thing that we implemented. And this was about trying to make it easy to do the right thing. And we empowered our theatre teams, identifying that they're mainly the permanent staff. So in terms of sustainability, if we want to make this just the way we do it around here, allowing them to implement things was very important. And so they came up with this idea of our emergency laparotomy trolley, which is just essentially a trolley which has everything in it that you need to deliver the bundle in theatre. So arterial lines and the LIDCO, which we use for goal-directed fluid therapy, and also the ODPs automatically set up the LIDCO for every emergency laparotomy, plus intensive care tracheal tubes, tubes for post-operative nutrition are all contained within the same trolley, as well as our paperwork and our pathway. And then again, this is just an example of what we would feed back. So very importantly, all of that is fed back to the teams. And this is our run charts for critical care post-operatively for all patients, and another example of our newsletter. So that's just a bit of a whistle-top tour through some of the things that we've done. We did have our work published in anaesthesia back in 2020, if anyone is interested in a bit more details of how we managed to achieve sustainability. Thank you.
That's great. Thanks, Leslie. That was really interesting. One thing that really sticks out for me is that you talk a lot about engagement of all your stakeholders. You've clearly got quite a lot of engagement, and especially with the exec team as well, which is great. And a lot of visualization and awareness. Those things that you feed back, how do you feed them back? Do you do it through email? Do you do it through face-to-face meetings? Do you do it through governance? How does it work?
Probably all of those things, really. So I think probably the best one is that we just print them out into some posters and pop them up in the theatres for people to see. But because I think that's good for the theatre teams and ITU. But yes, it's emailed to all of the anaesthetists, the surgeons. There's been various presentations at various multidisciplinary meetings on progress. But also the compliance goes to surgical governance as well.
Yeah, brilliant. And do you bring all the kind of specialties together? So do you meet as, you know, maybe ED, radiology, surgery, anaesthetics? Do you have like a joint governance or feedback meetings, or is it more that it's all done in silos and not as joined up as you'd like?
So it certainly was. When we relaunched the bundle, we set up a whole steering group and you know, had regular kind of monthly meetings and really relaunched. Obviously that we don't continue with that now, but we had just started pre-COVID a regular meeting. Actually, it was just the leads really, essentially. So in terms of surgical lead, anaesthetic lead, theatre lead, meeting to discuss any particular cases from the week before, or particularly to review laparotomies, and also trying to look at those that hadn't gone to theatre. But that has all fallen down with COVID. And again, part of that was also trying to engage and get involvement from ED colleagues, which is obviously a real key focus for us now. And yeah, so all of that's kind of a little bit gone to pot, but is definitely on my list of stuff to redo, because I think our focus really along the lines of the last NELA report as well is to get that multidisciplinary meeting going again with ED, with and work on an acute abdomen pathway outside of theatres for medical wards as well. So that's the bit about the code laparotomy. It works really well, but it isn't working kind of everywhere. So I think that's a really big focus for us. Okay, brilliant. Right, I've got some more questions I'll come back and ask you in a minute. So I'm going to hand over now to Orin Saha, who's consultant colorectal surgeon at Calderdale and Huddersfield. And Orin's going to talk to us about timely source control and also the use of laparoscopy and laparoscopic emergency surgery.
Thanks very much, Lyndon. Thanks to NELA and the Royal College of Anaesthetists for organising this. So really, what I wanted to do was spend a few minutes just talking about some of the changes in our emergency service here at Huddersfield, and to highlight some of the key differences in management that we've been able to achieve by making these changes, and possibly suggest some reasons for our improved outcomes over the years. And really, I suppose the take-home messages from what we've learned here at Huddersfield here really. Source control, to my mind, is the absolute critical part of managing these patients. And to do that, you need early and regular consultant input. I'll talk a little bit about consideration of the laparoscope, and finally just touch on the fact that it's not all about the laparotomies. I really think that it's about the whole system change for how we deliver acute surgical care that allows us to improve our outcomes. And I suppose the first thing to say is that we're a normal place. We're a normal hospital that you'll recognise up and down the land. There are 13 of us on the rota, 7 lower GI, 6 upper GI. But when we made our rota change, when we changed the way we deliver emergency surgery, there were only 9 of us. And over the time of the last 8 years of the NELA study, we've gone from 9 to 13 consultants. We don't have a subspecialty on call rota. Each of us does the acute rota fully, and we get trainees from the Yorkshire Deanery that go from between ST3 to ST6. We very rarely get senior trainees. And as you can see from the various charts produced by NELA, we're a normal place. Our chart here are the light blue bars for each of these operations and conditions. And the conditions that we operate on are the same as those up and down the land, predominantly small bowel obstruction, peritonitis, perforation, and so on. And the same goes for the operations that we do. We do some adhesiolisis, some small bowel resection, and some right hemicolectomies, and then other operations thereon in afterwards. We're a normal place with normal conditions and normal surgeries. But perhaps some of our bits are a bit abnormal. All of our consultants are on the acute rota, and we have really open and transparent job plans, so each of us knows what each other gets on their job plans. And crucially, we negotiated the acute part of our job plans together. They're the same. Everyone feels like they contribute equally to our service. Some of you may have heard us talk before about the Huddersfield rota, which involves a day consultant and a night consultant. And our change occurred kind of in the first 2 years of NELA. I won't spend too much time describing the detail of that, but I'm happy to if anyone wants to do that in the future. But ultimately, they were designed to meet the minimum standards of emergency surgical care put down in the Royal College guidelines over a decade ago, at the beginning of 2011. And what this has led to is a change in the culture of our acute service. And hopefully that then led to a really open and transparent approach to all our cases and complications. We're very lucky. We have an excellent governance and safety and quality meeting that was initially organised by Mark Peter, one of our consultants. And we discuss every patient who's had a length of stay over 5 days, every readmission, every return to theatre, every attendance to critical care, unplanned or otherwise. And it means that we're really on top of what's happening, and we get almost real-time data for any problems that we're having. So when you then think about what could be important to change a patient's outcome, to my mind, these are the things that we can impact in hospital: early diagnosis, early surgery, hopefully, of course, high quality surgery, and then what happens afterwards, critical care, medical input. And I do think it's important that we talk a little bit about patient selection. And I have worries in the past about hospitals whereby we may not be offering patient surgery if their risk is deemed to be too high. As surgeons, as our department, really these are the things that we have a little bit of an impact over. What can we do to try and maintain early diagnosis and early intervention as best as possible? I'll deal with the patient selection issue right from the outset. I don't think that's an issue in our place. You can see over the course of the NELA study, we've been doing more and more surgeries. And indeed, our predicted preoperative NELA mortalities have been rising as well. As we've noticed our mortality improving and our outcomes improving, I do feel like it's led to more confidence that we are taking on cases and offering patient surgery. But what you can see, these are our data from year 6, and these are really no different to previous NELA reports. Very, very few of our patients are actually getting to go to intensive care. So less than half of our patients with a risk of death over 5% last year went to intensive care, and only just over half with the risk of death over 10%. Undoubtedly, that was affected by COVID, and I've been amazed actually with the number of hospitals in this latest report who have reported 100% transfer of patients to HDU or ICU after emergency laparotomy. We've just not been able to achieve that. But even before COVID, we were only running at between 50 and 60%. So if it's not patient selection, and if it's not critical care, to my mind, there must be something that's explaining that our persistent and continuous reduction in mortality, this isn't a one-off data point, this is a trend in improvement in outcome. And the same goes for our real-time monitoring of mortality. And you can see that our predicted mortality consistently is higher than our observed mortality when we use our EWMA plots, which we engage with regularly in our department. So I think really there are very few differences in our department compared to other departments. And to my mind, the key thing is source control. Here's a plot of the interval from decision to operate to arrival in theatre nationally. But when you then superimpose our curve at Huddersfield over that, you can see that consistently from our rota change, we've been able to get our patients to the operating theatre that much quicker. We've been able to make that decision that much quicker and then intervene that much quicker. And there's only one reason that we've been able, because of the consultant presence for the entirety of the patient's pathway. The only real difference is time to surgery. And really, I think this is only achievable by genuine 24/7 consultant cover. If our patient needs a Hartman's at 6 in the morning, they will get a Hartman's at 6 in the morning. If there's a decision to be made at 4 in the morning, they will get that decision at 4 in the morning. The care that a patient receives at 2 in the morning should be exactly the same as that they would receive at 2 in the afternoon. But we have to find a way as a system, as a country, to deliver this without killing ourselves as surgeons. Many surgeons in the country at the moment, at least, are used to working 24, 48, 72, 96 hours. But our consultant surgeons who are coming through the system, who are very close to appointment, will never have worked a shift longer than 12 hours. And yet we now suddenly expect them to be moving into really the hardest part of their career as they get older and working shifts 2, 3, 4, 5 times longer than they've ever worked before. The other bit, which I think when we look at our data that I feel may have made a difference, is the greater use of the laparoscope. And you can see that our proportion of patients having open surgery has fallen. And our proportion of patients who are having laparoscopic surgery for acute has increased by a factor of 5. And I feel that when you actually then look at individual operations, there are some real operations where there are key differences in the Huddersfield data with that we see in the overall NELA data. So almost half of our patients with perforated peptic ulcer now have an entirely laparoscopic operation. But that compares with around 18 to 19% of the cases in the overall NELA database around the country. And again, you can see almost 40% of our patients having adhesiolisis are having laparoscopic surgery, and small bowel resection around a third. Now, I don't know that the laparoscope is the thing that's making people do better. But what I think is the use of the laparoscope is a marker for consultant involvement for the whole case. You know, a band adhesion is relatively easy to deal with via laparotomy with the registrar with relatively minimal consultant input. But the registrar may not be comfortable to do that case laparoscopically. So if the consultant is there, it means everything's being driven and everything being done that little bit quicker. And of course, it allows for greater training for our trainees as well. Of course, the laparoscope means that if you are converting, you can use smaller or more planned incisions. And of course, it makes it easier for easier pain management and early immobilization. Such that now within our department, the use of the laparoscope for emergencies is fairly standard. People don't question that. And the question is, why shouldn't you use a laparoscope rather than, is this case appropriate for the laparoscope? Finally, I just wanted to make one comment about the fact that it's not all about laparotomies. We're a medium-sized DGH. We do between 160 to 190 laparotomies per year. But this is in our overall burden of over 10,000 acute admissions. So it's really a small group of our acutes. But if you look at the hospitals who are presenting here today, Bath, Norwich, Cambridge and ourselves, they've not had, these aren't kind of blips in their mortality. They've had sustained trends in improved outcomes in NELA mortality. But they are also the highest functioning ambulatory units in the country. And I think getting all of this right, getting the whole system pathway right, is what makes your laparotomy care that much better. If you don't have an inpatient list with hundreds and hundreds of patients and 20 wards that you're having to trog around all the time, you can focus on the sickest patient, not just to deliver that first operation in time, but also to recognize complications and reduce that risk of failure to rescue after surgery. And it's really noticeable to me that the hospitals that I must say, we feel very proud to be on a group with the hospitals in this webinar. They're also the highest functioning ambulatory units in the country. And they've demonstrated a few things that are analogous to all of the units. Real leadership, a real commitment to emergency care. And although every hospital's done it differently, there's been a focus on job plans, infrastructure and recruitment. You can see that the right people are getting involved to deliver this. and a real culture of evolution of their service and continuous improvement. You've heard already from Bath about the importance of making sure that you don't rest on your laurels and so on. So those are the three things which I think are different about our outcomes, our process and our outcomes. And of course, I'd be very happy to take questions with the rest of the group for the rest of the webinar. And we're very happy to be contacted if anyone has any questions. Thank you very much for your time, and thanks for this chance.
Thanks, Oren. That was really, really interesting. Crikey, food for thought. Right, if everyone puts their cameras back on, then we'll go into a bit more kind of Q&A things while you're doing that. So, Oren, one of the things that you talked about is consultant presence, and that's come up in more than one of the presentations, talking about the importance of having sort of 24/7 consultant presence. 2 emergency theatres running in Addenbrooke's and at Norwich. Leslie's talked about how to escalate and open more emergency theatres, and that's really driven by having that consultant front door presence. So you've got to invest in your workforce, haven't you, and utilise that resource to the best of your advantage. Have any of you experienced kind of pushback from management, senior leadership teams about actually investing in consultant time to deliver emergency surgical care, or has that not been a problem?
Early on, it was a bit of a challenge. Certainly in our unit, we had really good leadership and management when we changed our surgical rotas, and then there was a change in management structures. And of course, you know, when you look at the bottom line, the easiest thing if you're new into management in terms of reducing costs is consultant salaries. And of course, that inevitably leads to job plan reviews. And for a period of time, there was a fairly difficult job plan renegotiation. But ultimately, senior leadership and management, when you kind of get them on board and show them the outcomes and show them the benefits of this, they recognize that this does take time. There are some constraints because of the consultant contract. That's not our fault. Acute care is expensive. Resident care, being around a consultant is expensive. But ultimately, everyone wants to have the best outcomes. And so once you're able to show the differences that you're making and that you're able to keep your side of the bargain, if you like, if you're going to pay the surgeons this much, this is what we will deliver. We will make sure we see the patients regularly, twice a day. We will make sure we commit to ambulatory care. We will get these laparotomies done at night if they need to do. And it shows that the hospital and the trust and the board are getting what they're paying for.
Okay, great. And Leslie, would you say that's the same from sort of an anaesthetic point of view? Have you had a similar experience?
Yes. I think we've always had an anaesthetic consultant in our emergency theatre in the daytime, for many years, and we have, in terms of the surgical allocation to that, I think the engagement with kind of managerial teams was really around having wasted capacity in the theatre if there wasn't a surgeon available, which then also promotes the fact that then there'll be delays, but also you'll end up in this chaotic kind of situation of potentially having to cancel elective theatres. So again, for a number of years, we've had a consultant surgeon also allocated to the CPOD list in the daytime. And in many ways, this is actually something that COVID has helped us with all of the changing rotas. So in fact, we now have a consultant anaesthetist available in that theatre resident till 8 every day, and so 7 days a week, and then not resident overnight, but in fact the surgical colleagues are doing much more resident and much more 12-hour shifts as well, actually. And there's been a real focus on identifying that, as Aaron said, it's really, really important to get that timely decision and that time to theatre, no matter what time it is. So as a consequence, there are more anaesthetists in at night, and that is being worked through on job plans. But I think, sorry.
Or consultants being on resident overnight as well?
Surgically, yeah.
Right, okay, brilliant, fab. Right, I'm going to quickly flick through some of the Q&A questions. This is the bit where I'm getting all a bit flummoxed and not very good at. So some have been answered already by various members of the team. Emily Slavin has got a question about the code laparotomy CT scanning. Now, I had a question about this, but slightly different to Emily's question. So who is able to request a code laparotomy CT scan? Does it have to be somebody of a particular grade? I know you talked about difficulties across ED and medical fields. For example, could an allied healthcare professional, emergency laparotomy senior nurse, are they allowed to request code laparotomy CTs, or is it something that's just...
No, so I think it does have to be a doctor. It does have to be a medical member of staff, but there's no seniority within that.
Okay.
But it is really only being used by the surgical teams. We need to spread that. So we have spread it, but it's not reliably being used, if you like, by medical and ED teams.
Okay.
And that's where we really need to embed that.
Okay, so then Emily's question was around the report. What grade is the report? Is it an SPR report, a consultant report?
I think it's mainly a consultant report, but again, it's whoever's doing that emergency reporting. But I think in our trust that is mainly consultants or an outsourced consultant.
Okay, all right, brilliant. Mike, you mentioned a surgical care practitioner for emergency laparotomy. There's a question that's come through about this, and that's one of the things I'd circled to ask you about. So one surgical care practitioner for preoperative workup and outpatient follow-up for emergency laparotomy patients.
Mhm.
Do you need more? How does that work? Is it really, have you noticed a really big benefit? Do they network with other similar healthcare professionals from other organisations? If you can answer that bit first, and then if anybody else has got a similar, just let me know that you've got somebody similar within your trust as well.
Yeah, so we have a number of surgical care practitioners across general surgical departments. There is one attached to emergency surgery. She is very helpful collecting the NELA data and the post-operative follow-up. There is a bit of cross cover with the other surgical care practitioners as well. So when she's on annual leave, there'll be some cover, and of course it works the other way. We also have a theatre coordinator for emergency theatres, whose job is obviously to coordinate the emergency theatres, and he works in a similar fashion, but doing the getting people ready pre-operatively and trying to improve the functionality of the emergency theatres. So there is a lot of working between the teams.
And are they able to do preoperative assessments, for example, for emergency laparotomy patients, or does that still come to the anaesthetic team?
For the emergency laparotomies, it will come to the anaesthetic team. For the smaller cases, the theatre practitioner can see them and assess them. So if their risk is, if they've got low risk and they're a minor case, but most of the laparotomies will, all the laparotomies will be assessed by the anaesthetist on the anaesthetic team.
Theatre efficiency, just being able to move the smaller cases through a bit quicker, probably, doesn't it?
Yeah.
So questions come in, how to contact other specialist nurses that are involved in NELA. We're looking at getting a nurse representative onto the project team. And one of the things I want to do is try and set up an allied healthcare professional kind of forum for other nurses and other allied healthcare professionals involved in NELA, and try and get them communicating with each other. So we're on to that. Right, let me try and find can we have more details of the traffic light system? Who and how is it calculated, and who implements it? Presumably that's a question for Leslie, and also Michael mentioned traffic lights as well.
Yeah, our traffic light system is, so it's essentially calculated from the amount of theatre time that's booked, if you like. So when a case is booked, part of the booking process will be asking how long that's going to take, and also obviously adding in anaesthetic time as well. And then there's an ongoing addition to accumulate the time booked into theatre, if you like. So that's where I was saying about we've been trying to get that electronic so it's automatically done, because at the moment it is reliant on someone calculating when you get to 6 hours. So after 6 hours, then you'd be going into amber. There's a sign on the door, or, you know, red, amber or green card essentially on the door that's, you know, stipulates what the status is at the time. But the idea is really at 4 hours, you're already thinking that another case being booked could potentially put us into amber. So it's a very dynamic thing that is dependent on the person in that emergency theatre as well. So there are, most of the time it works well, but there are some times when it's not quite so efficient as it could be, and that's why the electronic bit about that being calculated automatically. And the reason that it's obviously got to be dynamic is as a case is done, obviously then it might decrease again. So it's a very kind of but I think the message is that it's about being proactive, and so the anaesthetist, the coordinating anaesthetist will check in there at the beginning of the day as well, having known what's going on in all of the other theatres and know what the state is, what's booked there, can immediately identify whether something needs to or could be done somewhere else. So we're proactive before we get into the amber or red. So I think that's where it's had real benefit, is being proactive with your emergency cases already. But the reason that it's useful having it as a very established and agreed tool is that then there is no argument if we do have to go into other theatres. It's already signed up to, if you like, from the management team, and they are informed, and there's a formal process.
Right, okay, thank you. Mike, is it similar for you, or
well, no, ours is a different traffic light
electronic booking system? Yeah,
different one. It's for whether the patients are ready to go to theatre, whether they need assessment, and whether they've been booked.
Okay.
So
and do you feel that what Leslie's got at her organisation, would that benefit you at all at Norwich, having sort of dual traffic lights at the booking system point, and then being able to visualise how busy your theatres are? Because I think you've got the most number of NELA cases a year out of all of the presenters today. Yeah,
that's a fantastic system. As having two different traffic light systems would be complicated, but yeah, it's a very good system. We have a separate method for identifying when we're likely to get into trouble from a time perspective on the emergency theatres. I mean, it's effectively like most trusts. It's looking into bumping into elective theatres and stopping those, and so moving the emergency work on to other theatres.
Escalation seems to be a bit of a theme, doesn't it? About the pathway for escalation. Do you have that, Costas, in Addenbrooke's? What do you do when your two emergency theatres get full of cases? Do you have a procedure to stop the elective cases or not?
So we have one theatre just for general surgical emergency cases, and that runs from 7:30 until 12:30. And that's very useful because we can get lots of our cases, especially small cases, abscesses, appendices, everything through that list. The other list, which is a 24-hour list, we share with other specialties. But one thing we introduced is every morning about 8 o'clock in the morning, we all meet together, all the emergency on-call surgeons of all the specialties. We meet outside the emergency theater and we prioritize the cases. So everyone knows the plan for the next 12 hours, which case should go first, second, third, fourth on the list. So everything is well planned and there's no delays between cases. And that's how we use this system to try, and that way anesthetic team, surgical team, and all other subspecialties know exactly what's going to be going on in the emergency theater for the next 12 hours.
Yeah, brilliant. So everyone knows what's going on, don't they? That's great. Right, so we've got 2 minutes before this will boot us out. So very quickly, a couple of key messages from each of you that you think would be transferable to any organisation, not necessarily one that has your number of cases or your resource. I'll start at the top of my screen. Orin.
I think it's about rota changes and ensuring that the consultant surgeons have the time and the energy to be able to make the decisions and do the operations.
Okay, thank you. Costas?
I agree. It's the same as my title, multidisciplinary input at consultant level.
Yeah, okay. Mike?
Yeah, I mean, obviously, I was going to say electronic booking system, but on top of that, I think a very useful element has been the addition of surgical care practitioners in the emergency general surgical pathway.
Broadening the workforce. Leslie?
So I think mine would be multidisciplinary input at all levels, and particularly the team, to make it, how you do it around here, permanent members of staff, and feeding back, collecting and feeding back your performance.
Yeah, it's really great to see that all that kind of the use of the UMA charts and things that you've demonstrated. I think feeding back and engaging the stakeholders is really, really important. So thank you to everybody who's presented today. I hope that everyone has found that really useful and got some things to take away. If you want to get in touch with any of the speakers, we'd be more than happy to put you in touch if there's particular elements that you want to know more about. It looks like the Diploma for Geriatric Medicine's got significant interest, and it's brilliant that we had Nia Humphrey on, who was a geriatrician in Cardiff. So thank you, Nia, for representing the geriatricians in the NELA webinar. That's great. So I wish you all a pleasant afternoon, and hope to see you at the next webinar. Do complete the feedback and let us know what topics you'd like us to cover in the future. Take care.